My name is Daphne. I'm one of the subspecialist fellow in reproductive medicine over at the a tertiary center in Liverpool Women's Hospital. Today I'm going to talk to you about endometriosis and infertility and basically some of the hurdles that we might encounter and some common themes that patients have with us. I thought this picture was quite apt in the diagnosis of endometriosis, which you all will know is very multifaceted. And what we see is only the tip of the iceberg, and infertility is definitely one of them that we're going to focus on a little bit more today. So what we'll do today is have an overview of endometriosis, some theories of its origin. We're going to go into the nitty-gritty of the effect of endometriosis on fertility, and the area where you're most interested in is what are the management options in front of us. We'll finish the talk with some Q&A that's been sent in and some maybe that will be generated from the chat today. So you all know well what endometriosis is. It's an inflammatory condition that is characterized by the presence of tissue that resembles the endometrium, the womb lining, at sites other than the uterine cavity. The gold standard to diagnose endometriosis is by laparoscopy, which is keyhole surgery into your belly button and taking a look, okay? Commonly associated with endometriosis is almost what we call the cousin of endometriosis, which is adenomyosis. If we think that endometriosis is a difficult diagnosis to come to, adenomyosis adds on an extra layer of difficulty in diagnosis. And a lot of times patients would have dual diagnosis. This is quite a typical view of what we might find at the time of laparoscopy. So endometriosis comes in different forms and different severities, affects different part of the pelvis, and sometimes outside of the pelvis. Commonly, you can see what's described as powder burn lesions or gunpowder lesions, and they look like black superficial spots. But they can also look like white, dense, fibrous tissue. It can affect the ovary, and commonly these are known as endometriomas or chocolate cysts or endometriotic cysts. The anatomy can be quite distorted. It can affect your bowels, affect the bladder, and make the inside look a little bit anatomically different. And again, every patient have different extent to how the disease affects them. How common it is affects around 6 to 10% of women. And you see this mainly in the reproductive age. You see it higher prevalence in certain subgroups, especially in my cohort of patients that I treat are the infertility patients. The difficulty with making a diagnosis of endometriosis and the overall management of endometriosis is that the symptoms of endometriosis unfortunately doesn't correlate to the severity, staging, or extent of the disease. We know that because we have patients that have a diagnostic laparoscopy that doesn't have a high staging of the disease, but is very symptomatic. On the opposite end, there are patients that we would perform laparoscopy purely for sterilization reason because they have completed their family already and incidentally find extensive endometriosis, which obviously have not bothered them or bothered them not too much, but have not affected their fertility because they're now coming for sterilization. With endometriosis, we know that majority of patients are affected with a delay in their diagnosis. There are different layers to why this is the case. We know that there's a lot of limitation in the diagnostic tools that we use to make a diagnosis of endometriosis. We mentioned before that the gold standard is by keyhole surgery, by a laparoscopy. And that's because endometriosis doesn't always come up on scan. So majority of patients would have gone through an ultrasound scan, either transvaginally or through the abdomen. And that those imaging tools are just not sensitive enough, or if it doesn't affect, if it affects the ovaries, they would normally get picked up, but if it doesn't, nodules or gunpowder spots don't turn up on scans. What about MRI? Well, access to MRIs are not always very easy. And even when you've have had an MRI, it's down to the interpretation of the radiologist that's looking at the MRI, who may or may not have a special interest in gynecology. So it is a very trained eye that's required. If you end up having a diagnostic laparoscopy, there is some subjectivity as well to the diagnostic laparoscopy that you have, depending on who the surgeon is. And with a laparoscopy, although it's a minor surgical procedure, it comes with its own other risk. We're going to touch on this briefly on how do women get it. There's multiple theories out there, but really the real pathogenesis and the real reason why we get it is still remain unknown. We know that it's complex. And here are some of the common theories that are put out. So the oldest theory is by Simpson's, where he speculates that it's because of retrograde menstruation that it gets deposited into the pelvis. But if it was retrograde menstruation, then really we should see it more common in all women. What about endometriosis lesions that are not inside of the pelvis, are in the abdominal wall somewhere else, in the groin? And is this brought about by bloodstream? Is it brought about by your lymph system? Or more commonly, now there's new emerging theories that are from the stem cell origin theory, that lining from the womb can migrate out and move and implant. Whatever the origin of the pathogenesis is, the hallmark features are the same, which is that it causes inflammation and is very heavily estrogen driven. I believe you recently have had a talk that went into quite a lot of details about staging endometriosis, so I won't touch upon this too much, but the American Society of Reproductive Medicine have revised the classification of endometriosis and its staging really by using this chart. This is quite old. It's very detailed though. Now, this is a part where you've signed up for this webinar for how does endometriosis affect fertility. What we know is that through large population data is that chances of getting pregnant can be reduced if you have a diagnosis of endometriosis. There is some correlation to the degree of reduction in difficulty in getting pregnant to the severity of endometriosis, but this relationship is not necessarily linear. What that means is that if you're diagnosed with stage 4 endometriosis, doesn't make you automatically the most difficult groups to get pregnant spontaneously, okay? Compared to your to other patients that with a lower staging. We will come back to revisit that idea in a little bit more, and we'll explore that later on, okay? The investigation workup for infertility is not dissimilar for patients that are affected by primary or secondary infertility. The diagnosis for the primary and secondary infertility groups largely overlaps, okay? What that means is that if you're having difficulty and you've never gotten pregnant before, the workup is very similar to somebody who's had a child and then trying for a sibling but having difficulty then, okay? What's slightly dissimilar is the prognosis of getting pregnant, okay? So if you have been pregnant before, more than likely your prognosis is going to be a little bit better, and therefore might lead your fertility specialist to make a more individualized plan that's slightly more different. Again, we will revisit that and explore that in a little bit more detail in subsequent management talk. But before we move on, let's have a little revisit of some of the definitions that I'll use here and some of the terms, because they can be quite confusing and there's a lot of words that get thrown around. Okay, so primary infertility refers to someone who's never conceived a child in the past and now has difficulty conceiving after trying. Secondary infertility is where someone has had one or more pregnancies in the past, but is now having difficulty conceiving again. You would hear the word ovarian reserve quite commonly. So people say, test for your ovarian reserve, test for your ovarian reserve. There are a few ways of testing for your ovarian reserve. Some are cycle sensitive and some are not. So the commonest one is called follicle stimulating hormone. So in short, FSH. FSH is a cycle sensitive one. So we want this hormone to be low, and we want to take that hormone level around the time of your menstruation. So day 2, day 3 is an ideal time to do it. Majority of the time, this test can be done by your GP. Anti-Mullerian hormone is not time sensitive. It can be done at any time of the month. And we want this hormone level to be high because this hormone is produced by follicles in the ovary, whereas FSH is a hormone that's produced in your brain that drives the ovary to produce eggs. Antral follicle count is also an ovarian reserve test. This is done by ultrasound scan. So you can see how now some of the tests are a little bit accessible, some of the tests are a little bit less accessible, some are a bit easier to do, some are not as easy. So like a scan is not as easy, and it's also more dependent on the practitioner that's doing it for you. One of the caveat to ovarian reserve testing is that it tests for your fertility potential, okay? It predicts, really, these are validated tests to predict the likelihood of ovarian response to drug stimulation when it comes down to IVF. So it doesn't predict really the fertility potential on somebody who's trying to conceive naturally. If we dial back and consider in a very simplified manner, what are the prerequisites to get pregnant, okay? Then really it comes down to these 4 ingredients, which is to get pregnant, we need the ovaries to have a good reserve. So there's a good amount of eggs there. So somebody who's not gone through menopause, and that can be tested by means we've just discussed just now using anti-Mullerian hormone, follicle stimulating hormone, or antral follicle count that is done on scan. We need eggs to be released by ovulation. We need the function of fallopian tubes, which forms the bridge where the egg would then meet the sperm, which is the 4th ingredient to form an embryo. And then this embryo that gets this egg that gets fertilized by the sperm that has formed an embryo then would have the fallopian tube function to help it move down to the uterine cavity for it to then be implanted. So if those are the 4 things that we need, how can endometriosis affect it? So these are some proposed mechanisms. Some are easier to visualize and to get our head around. So in severe endometriosis, where there's a great deal of distortion of the anatomy, where the tubes are swollen, the tubes are blocked, buried behind, it's understandable and you can visualize how this can affect your fertility. Ovarian reserve compromise. So ovaries carries eggs and have the function of doing that. And we're born with all the eggs that we will carry for the rest of our life as baby girls. If your ovary has an endometrioma, which is a space-occupying lesion, ovarian reserve can be compromised. Now, add on to the fact that if you have endometriomas being operated on, so if you have ovarian cysts there and you operate on the ovarian cysts, you could potentially be taking away healthy egg-producing function of the healthy tissue. and that can impact on the pool size of the egg there. We know that endometriosis can lead to chronic pelvic pain, and painful sex may prevent time intercourse, and then potentially patients are losing their fertile window. The other things that are a little bit more abstract, I would guess, is we know that endometriosis is associated with chronic inflammation, this increased immune cells. We know that from lab studies that if we were to take fluid from the peritoneum in patients that have had endometriosis, we have the increased immune cells. We know that their implantation window and receptivity could be slightly shifted. There is also some correlation studies that suggest that the egg and embryo quality might be affected. And these are largely in egg donation programs where patients that receive eggs from egg donors who are patients who are affected by endometriosis, if they were to receive eggs donated by donors that don't have endometriosis, they perform as well as somebody who doesn't have endometriosis. Well, knowing all that knowledge, how does it help your fertility doctor or yourself or your general gynecologist make a recommendation of how to move on? Should we always consider surgery? Is it always on the table? And if so, when should we do it? Should we do it before we try? Should we do it after we tried and have not been successful? And if we were going to do a surgery, how much surgery do we do? Do we try naturally first? And if we were to try naturally, how long should we try? Should we not and just go straight for IVF? What about IUI? It's less invasive. We don't have to take injections for that. Or if we're actually going for any hormonal, fertility treatment, should we have some downregulation with hormones before, after surgery? It's all very confusing. And I think it's an arena that is always slightly neglected because patients go through the service in a little bit of a pocket. Under the endometriosis team, who is there mainly to help with majority of the patients going through that having a lot of pain, and the pain symptoms then gets prioritized. And sometimes you're not seeing the right person, and maybe the right questions not being asked. But hopefully some of the upcoming slides that we have here can debunk some of the questions in your head. But the key to management, especially with endometriosis and fertility, is individualized care. Okay, because there's no one case that's similar. There's cases that are similar to the other, but it's not going to be exactly the same. And individualized care and coming to a joint decision making here. Okay. So one of the things that I like to draw to your attention is, if you haven't heard of this before, it's the Endometriosis Fertility Index. Okay. This is a validated study that was conducted by a Californian group. I think this was published around 2010. And in essence, what it's looking at is the function of the adnexa, taking into account that the patient history and your severity of endometriosis using the staging scoring, and coming up with where we would recommend how to try for fertility. Okay. So firstly, we're looking at the score of the adnexa. So scoring the ovary, the fimbral end, which are the finger projections of the fallopian tube, and the fallopian tube itself, and taking the lowest score of the left side or the right side. One of the main thing using this scoring system is that it needs to be scored at surgery. Okay. So if you were to have any surgery and you're having optimization surgery, you're having treatment surgery, and we're doing surgery on your tubes, your ovaries, this score is the score at the end of your surgery. And then the score would be coupled together with your historical score. So taking into account these three things that are deemed to be the most effective, the most influential in your fertility potential. So female age, unsurprisingly, the duration since you've been trying, and whether or not you have had any pregnancies before. And this prior pregnancy doesn't have to be natural conception, it could have been through fertility treatment. Taking the patient's background together with your score at the time of surgery, and also the endometriosis score through the fertility staging system. And it gives you a total score of the three things. And what they've done is use this score to predict patients' chances of pregnancy spontaneously or with IUI, so not using any fertility drugs, okay? And this is the sort of picture we're looking at. So on one side, the percentage of getting pregnant. On the lower horizontal line is the time to try, okay? So the higher the score, the better the prognosis. And you can see, regardless of what scoring you get, really sort of almost towards the 18-month timeline, you're seeing a plateau in the line. And that's why you hear endometriosis specialists, gynecologists or fertility specialists saying that even in the really good prognosis patient, but really try sort of in the next year, coming up to 18 months, because then you're not seeing much increase in pregnancy rates spontaneously anymore. But what I want to emphasize is individualized care, precisely because no one size fits all, and there is so many little things to consider, okay? And these are the sort of spider web of areas that you might ask. So we talked about prognostic factor, okay? We talked about ovarian reserve, patient's age, and other infertility factors. So, and that includes, so the score that we talked about just now doesn't take into account whether or not there's any uterine factors. So anything affecting the womb itself, large fibroids going into the womb lining, womb that are different in shapes because of congenital, that's how you're born. And it doesn't take into account sperm parameters. So if you are a good prognosis patient on the previous slide that we worked out, you've got a good score, your chances of getting pregnant spontaneously is good, but your partner has a very low sperm count, then the fertility doctor might say, actually, on balance, we're going to go for IVF treatment, because there potentially is more than one reason of the delay, okay? What other treatments have you had surgically in the past? What are the service structure in your regional center? So, for some areas, your hospital is not a tertiary center, or there's no setup for endometriosis services, you have to be referred to your regional endometriosis services. There are potential delays that might make your in-house fertility doctor say, hey, you know what, you're looking at an 18-month delay in getting surgery, and with COVID and the wait list, why not go through a cycle of IVF treatment, because there's potentially time lost here, okay? And then there's concurrent tubal disease, anatomy distorting cases where you might say, actually, let's have a low threshold going for IVF straight instead, or going for surgical treatment, because the tubes are swollen with hydrosalpinge Gs, we should remove them. What are patient symptoms? If you're very symptomatic of pelvic pain, you might want to prioritize dealing with that over your fertility intention. Where are you in the stamina tank? And that's one big thing that we don't measure. We measure blood tests, we do laparoscopies, we put you through systems and referrals and all those things. We don't measure how much stamina you have in your tank. And that's a big thing that I think it's easy to ignore, especially when, it's a busy clinic. The Other practical things are funding around fertility treatment and funding criteria in your local area, and what's your access to NHS funded fertility treatment. What kind of relationship are you in? Are you in a heterosexual relationship? Are you in a same-sex relationship? Are you a single lady? These would come into question when you're applying for NHS funded IVF. There are some guidance and evidence out there that helps make recommendation on what we should do. They're a little bit old and they need to be updated, and they're not blanket treatments, I think. But one thing to discuss, and I think was negligent not to mention this in the fertility arena, is that fertility treatment is very ageist to the female. It unfortunately, age is a very strong fertility prognostic factor. So here we can see the rate of getting pregnant per month by age. And you can see that a 22-year-old has around about 25% chance every month to get pregnant. A 35-year-old around just over 15%, 17% chance. But although the chances per month seems to not be very promising, what we know is that there's a cumulative effect of the pregnancy per month, okay? So let's, for argument, pick 15%, okay, of chances of getting pregnant per month. After 2 months, it increases to 28. After 3 months, 39. So if you look at the 9-month timeline, looking at around excess of 70% getting pregnant spontaneously. Those are pretty good odds. And that needs to be balanced against the control of disease, your symptoms versus your fertility potential. So going for surgery, there's always on the table the risk of surgical complication. And that includes if you have an endometrioma, which is an endometriotic cyst affecting the ovary, then operating on that ovary always risks potentially losing that ovary and losing healthy tissue and egg producing ability. Surgery comes with it, recovery time, potentially reducing ovarian reserve, and delaying in your IVF treatment if that was ultimately needed anyway. However, the gains are vast as well. So fertility treatment can improve symptoms, potentially increases chances of getting pregnant spontaneously, and improve access to getting to the healthy follicles when it comes to fertility, when it comes to IVF treatment, when it comes to collect eggs. Cannot emphasize more that treatment for fertility has to be individualized. There needs to be thorough counseling, and we come to a joint decision together. But if we have to talk about some usual indications where we will be more inclined to offer surgery, is that patients are very, very symptomatic of a lot of pain. There's definite evidence of hydrosalpinges, which are swelling in the tubes. Endometriomas are very large, and they may impact on getting access to the healthy eggs or follicles that are behind it, okay, when it comes to IVF treatment. Here are some general rule of thumb in terms of what we tend to follow, and most fertility specialists would err on this kind of treatment plans. So in somebody who has no symptoms and you incidentally found an endometrioma, patients have regular periods, then the recommendation normally is to consider trying to conceive naturally. If endometriosis is mild, then we would consider performing surgery to excise and take away the endometriosis, and at the same time gives us an assessment of the function of the tubes, and then try to get pregnant, because there's some evidence to say that this improves your spontaneous pregnancy rate. If endometriosis is of a higher staging, then rather than performing operative laparoscopy right away is to consider that, but having a think of whether or not we should be offering fertility treatment first before surgery, okay? If there is an endometrioma and we decide to operate on that, then the recommendation is to not just drain the endometrioma, but to remove the capsule to reduce the endometrioma returning, okay? Every time we do that, we have to consider losing healthy ovarian tissue. So it's not a bad idea actually to know where we stand in terms of ovarian reserve before we go ahead and do that. If we're doing surgery and patients have intention to try and get pregnant, is to try in that sort of 12 up to 18 months, I would say. This is a flow chart that is quite popular. I think it was a French group that published this. In essence, if you have endometriosis and you're going through an infertility workup, measure ovarian reserve and see where we stand. If the ovarian reserve is low, we know that we've got less time to play with, then the inclination is to go straight for IVF treatment. If ovarian reserve is okay, we know that we most likely we're not rushing, then go ahead and look for whether or not there's any other reason why we should be doing IVF. So sperm test is one of the common things. If there is multiple factors for infertility treatment, then go straight for infertility treatment already, because even if you have a perfect pelvis, there's still a sperm problem there, okay? Now, if we've got good ovarian reserve, sperm looks okay, then it's assessment of fallopian tube. Fallopian tube is not great, go for surgery. Otherwise, straight to IVF treatment. And after surgery, we say again there, 6 to 18 months for spontaneous pregnancy, provided that we've got, provided that female age is okay and we've got good ovarian reserve. If you reach this point and we see that positive pregnancy test, then yay. Symptoms tend to get better when we're pregnant because of the relatively high progesterone environment that we're in, okay? If you have an endometrioma and you were to fall pregnant, like any ovarian cyst, there's a small risk of rupture, okay? If you are normally quite good on hormonal treatment in terms of symptomatic relief from endometriosis, then after giving birth, hormonal treatment can be restarted right away. That is the gist of my talk. I'm happy to take questions.
Okay, thank you so much, Daphne. That was so interesting and so thorough. Thank you. I'm going to start with the first question. So first one we've got through is it possible for someone aged 35 and over to naturally conceive without IVF as eggs start to decline from that age onwards?
The general answer is yes. Let me actually go back to my slide, because I think that was quite a useful slide to just help people visualize it. So this, the answer is yes, because it really comes down to what your endometriosis fertility index is. If you've got normal tubes, normal ovary, and endometriosis affects you in areas that are not in the tube and ovaries, then you would have a pretty good score. 35, you'll score 1. If you haven't been trying for that long, you score 2. So overall, your score ultimately will add up to be quite high, and you might be in the 9 to 10 or 7 to 8 group, which means that you've actually got a pretty good prognosis, I think, of trying spontaneously. But bearing in mind, this is the sort of timeline. So 12 months, 18 months, we start to have to think about needing some help potentially.
Okay, thank you, Daphne. The next question is, can the following history affect your fertility, and to what extent? So stage 4 endometriosis, removal of large endometriomas, multiple laparoscopies, left ureter damaged and repaired, fallopian tubes previously blocked, and hydrosalpinx diagnosed, as well as being on medication to combat pain and then also stop endometriosis from growing.
Yeah. So I think when you sent me over that list, this patient was asking about being on the mini pill. So mini pill and pregabalin, I think, was the
Yes.
two medications. So pregabalin is not fertility impacting, but mini pill is a contraceptive pill. So that would have the unwanted side effect of contraception in somebody who's trying to get pregnant. So that would affect it. The other things that was mentioned are large endometrioma, 10 centimeters, having had a hydrosalpinx. If both of them are on the same side, then this would be still okay. But if they're on different side, the score for this would be quite low, which means that the egg producing potential and the tubes accommodating potential is low. So this patient is going to end up with a very low score and most likely will need treatment to get pregnant rather than spontaneously, I think.
Okay, thank you. You might have covered this already, but I've got, why is one IVF attempt? Why is it that when one IVF attempt is successful and then when trying again, others may not be? And when this happens, what do you suggest as a solution?
Good question, but unfortunately too non-specific a question. IVF success is multi-layered. So in a patient that has a diagnosis of endometriosis, we can be tunnel vision to thinking that it's all endometriosis related. Unfortunately, there's more to it in IVF because there's also sperm, there's also fertilization, and then the embryo that results from that. And also, in addition to all of the above, it's the stimulation protocol that that you go through in IVF. So you might be using a different protocol and therefore have responded differently, may have produced more eggs in one cycle compared to the other cycle, and that would influence IVF outcome. So need a little bit more information on that particular question.
Okay, thank you, Daphne. And the next one is, so how do you speak to an endometriosis specialist on the NHS? And this is coming from someone with stage 4 endometriosis that was discovered by a fertility specialist, but they don't seem to be, they don't seem to care about the endometriosis only to the extent to which it affects fertility.
Again, good question. Then what I would ask is, so most fertility specialists have got actually quite a lot of training and experience in managing endometriosis. Most of us would be operating on patients that have endometriosis as well. The question is, the indication for referral to an endometriosis specialist, is it because we're now thinking that we need to operate to optimize fertility, number one, or are we thinking that we need an opinion from an endometriosis specialist because now patients developing more symptoms? So that would be what the time when I would refer to my endometriosis specialist colleagues. But if you want a second opinion from an endometriosis point of view, then BSGE, which stands for the British Society of Gynae Endoscopy, has a list of endometriosis center regionally. As a patient, you can log on to, just Google their website, BSGE, and you can find out where is your nearest and ask. There's no reason why you can ask your fertility specialist to refer you.
Okay, thank you. So what are the chances of spontaneous pregnancy with stage 4 endometriosis?
Right, great. So we've mentioned just now in these 3 slides that staging is not directly relevant, it's not a linear relationship to your chances of spontaneous pregnancy. It really comes down to, even in a high staging patient, what are the status of the tubes, ovaries, and the fimbria, which is the finger projection of the tubes. You can have stage 4 endometriosis, but have relatively limited disease to the tubes, ovaries, and fimbria, which if that's the case, your fertility prognosis is actually pretty good. Coupled with the other historical factors, which are your age, how long you've been trying, whether or not you've been pregnant before. So staging on its own only carries some of the score to your potential prognosis. So you could still score, 6, 7, which is pretty good prognosis in somebody who's actually got stage 4 disease.
Right, thank you. And following on from the that question, how does this change with surgery? For example, if a large 10 centimeter cyst is drained, not removed, just drained, and one fallopian tube is removed or tied up, will it increase their chances of a spontaneous pregnancy?
It depends, as one of the previous question, it depends on whether or not your tube and ovarian disease are on the same side or on different sides. So if they're on the same side, your chances are a bit better. If they're on different sides, you've got one tube tied, one ovary operated on, then it would reduce your score quite a lot.
Okay, thank you, Daphne. My next question is, are there any ways to increase fertility chances when you have endometriosis and hydrosalpinx?
Hydrosalpinx, that's a really good question. Hydrosalpinx need to be treated, but it really comes down to the expertise of the surgeons and how much more is the pelvis affected. So hydrosalpinx just ideally should all be gotten rid of, and then going ahead with IVF treatment if the patient's got very severe tubal disease, but it's how easy to get to the tubes to operate on them. So this might be a regional center operation.
Okay, thank you. So is it true that the first 6 months after excision surgery are the best to try to conceive?
So 12 to 18 months, up to 12 to 18 months, we see a plateau. So provided that you've got a good fertility potential, so good ovarian reserve, you're pretty young, then trying naturally for up to 18 months is acceptable.
And do you recommend any vitamins or supplements to help with endometriosis symptoms?
Not vitamins or supplements, but there are some suggestion that a low FODMAP diet would be beneficial in symptomatic control.
Okay, and yeah, so the next one is there anything people can do to fall pregnant naturally after having laparoscopies?
So it depends on, it's difficult because it needs to be individualized. So without knowing how the extent of the endometriosis that you've had and the surgery that you have, it's difficult to answer that question, because if the surgery that you have was actually clipping both of the tubes, then there's 0 chance of spontaneous pregnancy. But if it was excising endometriosis in the ureter, it's far away from the fertility, the tubes and the ovaries, then your chances of getting pregnant spontaneously is actually really good. So without knowing, it's difficult to answer that question specifically.
No worries. So if any, are single women with severe endometriosis eligible for egg freezing?
Say that again, sorry.
Sorry, if any, are single women with severe endometriosis eligible for egg freezing?
Yes and no, because it depends on what the next step is in your fertility journey. sorry, in your endometriosis treatment. So if you're a single woman and you have stage 4 disease and you're in a lot of pain and your endometriosis specialist is recommending surgical treatment that would affect your ovaries, then egg freezing is absolutely something to consider. And then the next hurdle is to get NHS funding, which is variable in different places depending on what your funding body is. So some CCGs would say yes when your surgery is in place already. Some CCGs would make you go through an individual funding request. So it depends.
Okay, thank you. Does having, this has just come in, so does having moderate endometriosis and mild adenomyosis affect the success of IVF treatment for secondary infertility? And if so, is there any considerations one should take into account before proceeding with IVF, for instance, the drugs?
Good question. Again, it depends on, tell me again, she's going through IVF treatment already, this question.
So hold on, let me just read it again. So does having moderate endometriosis and mild sorry, I was stumbling on that word, but we know what I mean. Yeah. Affect success of IVF treatment for secondary infertility. So I don't know if she started already, and if so, is there any considerations one would take into account before proceeding with IVF? For instance, will the drugs make endometriosis worse? So I think she hasn't started yet.
Yeah, so adenomyosis is a difficult one because the diagnosis is not easy. Adenomyosis is a diagnosis of histology, but you can see some changes usually on scan. I think there are some protocols that in IVF treatment that might make patients with endometriosis respond a little bit better. Some fertility specialists believe in frozen embryo transfer cycle for all endometriosis patients. A bit debatable. There's no definite you must go on this protocol, must use a long down regulated cycle. But generally for endometriosis patient, we tend to use a long down regulated cycle and then start stimulation that way.
Okay, thank you. Is the presence of a chocolate cyst a conclusive diagnosis for endometriosis, or would a person still need a laparoscopy?
So you can only say that it's a chocolate cyst when you've actually seen it on laparoscopy, but majority of the time you can actually endometriomas are very distinct on scan, so you don't necessarily need a laparoscopy is my answer. The question is, knowing that the size of it and it needs to be coupled with how big it is, patient symptom, and their intention of getting pregnant and whether or not they've tried it all. So if it's a patient that has that found incidentally on scan, is relatively symptom-free, hasn't tried to get pregnant or have been trying for actually not that long, then and it's relatively young, then my recommendation is to try a little bit longer.
All right, thank you. If you are going through excision surgery, are you able to have a fertility assessment, for example, to check tubes are clear at the same time? Or does it need to be done by a fertility specialist rather than an endometriosis specialist?
No, can be done by whoever that's performing your laparoscopy at that time.
All right. So someone has I've read that an endometrioma is indicative of stage 3/4 endometriosis. Is that true?
Yes, because according to the score, the AFS scoring, which is here, endometrioma will score you a point of 16. So 16 is already in third stage. So if you have anything, if you have bilateral endometriomas, you're at least a stage. If you have one endometrioma, you're at least a stage 3.
Okay, thank you. Would an
Unless it's very small. Sorry to interrupt.
Oh,
Very
no,
small.
sorry. Okay, unless it's very small. All right. So would an endometrioma usually be seen whilst doing a Hycosi test? Hopefully I pronounced it right.
Yes, it should be. If you're a good practitioner should be scanning your ovaries. So yes, is the answer.
Perfect. And if someone has an endometrioma and falls pregnant, what would happen if it ruptured? Would the pregnancy still be okay?
Yes, patient would be in pain.
Okay.
And the problem is when you're pregnant and you're in pain, the doctor taking care of your pregnancy would be quite tunnel vision in thinking that the severe pain that you're in must be related to labor. So sometimes people don't think laterally to think that, oh, it's a non-pregnancy related issue. So let's, for example, say you're 28 weeks, you had a known endometrioma that's, I don't know, 8 centimeters. You're ticking along in your pregnancy just fine, and that endometrioma popped. And you turn up in hospital and people would see your bump and you're 28 weeks and you're in pain. What does the doctor think automatically, or a midwife? They think that you're in preterm labor. So that would be almost the first initial thoughts, rather than, oh, it's her endometrioma. That's the diagnostic dilemma when it comes down to that.
All right, thank you, Daphne. And is it true that endometriosis brings a higher risk of miscarriage and ectopic pregnancy? What are the risks and how can they be managed?
Very good question. Ectopic pregnancy potentially, because anatomy is distorted. A lot of endometriosis patients can have tubal disease. So when you have tubal disease, your risk of ectopic pregnancy is higher, because most commonly ectopic pregnancies happen in tubes. Miscarriage is a little bit of a controversial one. Some association, but not definite.
All right, thank you. And how does endometriosis affect the success rate of embryo transfer once you've got good quality embryos?
The success of embryo transfers.
Yeah.
If you're on a good protocol, I would say that your chances are pretty much the same as everybody else. The problem is underlying that we know that patients that have endometriosis can have some altered immune reaction. So you can have raised immune cells, lower immune cells. You can have endometrium receptivity that's slightly altered, but those are at a cellular level. We won't know. So I think in the event where you have had good quality embryos, you've had multiple transfers, and it has not been successful, and that would be when we will actually start thinking, if it's not embryo related and it's line, it's a lining, then the next thing is to start thinking about endometrial biopsy, looking at receptivity, microbiome, and all these things that are right now in an immunoprofiling, and right now that's still in research arena that has no definite, right or wrong or definite treatment options for them. But that would be what I say. If you're a patient that has a diagnosis of endometriosis, you have good quality embryos, your IVF treatment's otherwise very straightforward, you've got good response, but you keep putting embryos in and you don't get pregnant, is starting to think about the line. And the only way of knowing is to biopsy the line.
Okay. And this will be the last question, just because we're running out of time now. But how can endometriosis be managed while not on hormone treatment when trying for a baby?
It's a good question. It's a difficult one. If you're if you're good on if your symptoms are well controlled on hormones and you're trying for a baby, then hormone is just a big no, because it gives you the unwanted side effect of contraception. It's being um, it's being a little bit more creative and thinking about whether or not there's other pain meds that can help you with. And some patients, it is finding the right sweet spot for them. In some people, is exercising. Some people, is dietary changes. In some people, it's considering surgery.